objective of my presentation is we want to know why to use. Does it really change imaging? Does it really change endpoints, surrogate or clinical? When to use, how to use, and is one better over other? So, so first of all, we'll see the trials before 2023. These are the old trials. I'm not going to go into details of these trials. These are very well established trials like music trial, which was the first trial which came in 1998 and which gave us the music criteria, which has been used in iOS for a long time. iOS XPL, iOS CTO, there were various meta-analysis which came into Illumine 1, 2, 3 trials, Mozart trial and Ultimate trial. So Ultimate was again an important study which came in around 2018 and which gave us the ultimate criteria which has been widely used for iOS nowadays. So if we have so much data, why new trials? The trials enroll too few patients for evaluation of hard clinical endpoints and focus on narrow group of lesion subsets. And we are limited to short-term follow-up. This was the reason we had need for new trials. And the problem was there was no uniformity of criteria which were used to define stent optimizations, and the inclusion of patients included first generation trials, first generation drug-eluting stents. So 2023 was a very important year for imaging trials actually, and 4 trials were presented in ESC 2023 and one trial was presented in ACC, and this is actually the year of imaging trials basically. So Renovat complex PCI was the first trial which was presented in ACC 2023, and it was a imaging trial, intravascular imaging, where both IVUS and OCT were used, which were compared with the angiographic guided complex PCI. And this was a trial which enrolled around more than 1600 patients and 1000, it was a 2:1 randomization. Around 1000 were randomized to IVUS intravascular imaging guided PCI and 547 to angiographic guided PCI. If you see this, these patients were very complex patients. They included bifurcation lesions, CTO lesions, Leishman bifurcations, long lesions, multivessel disease, all kinds of day-to-day what we get, all complex patients. And here IVUS was used in 75% of the patients in the imaging arm, and 25% OCT was used in this arm. And what was the primary endpoint was a target vessel failure, which included cardiac death, TVMI and TVR. And you see the significant reduction in the events at the end of 3 years, 12.3% versus 7.7%. This is a significant reduction in the primary endpoint in these patients. And if you see the death, MI, all secondary endpoints also were reduced. If you see the stent thrombosis was 0.1% versus 0.7%, TLR was 2.6 versus 4.4. Significant reduction in the secondary endpoints even. So this was a very positive trial which showed imaging guided PCI reduces the hard clinical endpoints. Now this was again a very awaited trial, Illumine 4, and after 1, 2, 3, everybody was hoping this will give a very good result. This was a study, it's a very well-planned study actually, and Ziad Ali was the primary investigator in this. Randomization was 1:1, OCT guidance versus angiographic guidance, and what was done is the OCT guided PCI was followed pre-procedure OCT, post-procedure OCT was done, and primary endpoints were acute minimal stent area and target vessel failure at 2 years. But in angiography arm, the end result, after the procedure was completed, there was a blinded OCT which was done in all patients so as to compare the primary imaging endpoint. And around, this is around 1200 patients, more than 1200 patients in both arms, and 2 years follow-up was done. And actually during this trial, the COVID came. So primary imaging endpoint, this is a surrogate endpoint which showed MSA of 5.72 in OCT arm, and angiography showed 5.36. This was significantly higher MSA were achieved with OCT guidance, and the p-value is significant over here. But primary clinical endpoint, there was not much difference. The target vessel failure was similar in, it was non-significant reduction with OCT, and statistically it was not significant at the end of 2 years. Thus, if you see the other secondary endpoints, the death was relatively lesser with OCT arm, MIs were relatively lesser, but they are not statistically significant. But stent thrombosis was statistically reduced with OCT. So the conclusion of this trial was OCT guidance resulted in larger MSA than angiography guidance with greater stent expansion. The complications like dissections or malapposition, tissue protrusions were lesser with OCT guidance. It reduces the angiographic complications. There was no difference in the target vessel failure between OCT and angiographic guided PCI. And OCT guided PCI significantly reduced the stent thrombosis. There are trends in fewer cardiac deaths and MI with OCT guidance, but they were not statistically significant. The problem in this trial was what they reported even in NEJM is the COVID came and the patients reporting to hospitals were less. They avoided coming to the hospital. So overall event rates in both groups were lesser. So that was one thing. And second thing, what they proposed is the angiography group, OCT was done blindly in all the patients, but still sometimes there was some major thing which was treated in these patients. If like a major dissection was seen on OCT, they treated those patients. So that might be the reason of, so this trial in a nutshell was like surrogate endpoints were positive, but overall clinical endpoints was it was like a equivocal. In the same ESC, one more OCT trial was presented, which was an October study, and this was a study in bifurcation patients basically. The patients having bifurcation, OCT guided versus angiographic guided. Again, it's a big trial, 1200 patients randomized, half to OCT guided and half to angiographic guided PCI, and again primary endpoint of MACE at 2 years was studied. Now these patients were bifurcation patients where side branch was more than 2.5 millimeters and more than 50% stenosis in both vessels. If you see the procedural characteristics, almost 65% of the patients needed 2 stents. So most of the patients required 2 stent strategies in this group. And if you see the results, at the end of 2 years, OCT guided PCI had lesser event rates, MACE as compared to angiography guided PCI. And if you see the MACE death and IDTLR and stent thrombosis were lesser with OCT guidance. So this was a positive trial which showed OCT guidance reduces MACE especially in bifurcation lesions. So 2 trials, one negative kind of and one positive were presented in ESC. Now this was a meta-analysis which Greg Stone presented in the same ESC meeting. And these were meta-analysis of 20 randomized trials. Actually, 2 were excluded. Now, if you see OCT versus angio, OCT IVUS versus angio, IVUS versus angio trials, these were included. OCT versus IVUS, which were 2 trials, were excluded from this meta-analysis. And even Illumin 4, October, and Renovate Complex PCI, which were the latest trials, were included in this meta-analysis. So this becomes a very important meta-analysis. And if you see the hazard ratios and relative risk reductions, which were significant across all outcomes, basically all endpoints like target lesion failure, cardiac death, TV, MI, TLR. If you see the stent thrombosis, it's almost 52% reduction in imaging guided PCIs. So almost across all endpoints, there was a positive impact in this meta-analysis. In the same meta-analysis, they compared OCT versus IVUS. There are 4 trials which were comparing OCT versus IVUS. Almost equal results. If you see, there was not much difference except for TVR, where IVUS was little better than OCT in this meta-analysis. But overall, it's an equivalent result versus OCT versus IVUS. Now, this Korean group presented Octavius trial or OCT IVUS trial in the same meeting ESC, and here again the comparison was between OCT and IVUS. Here more than almost 2,000 patients were recruited, and 1,000 patients in OCT and 1,000 patients in IVUS guided PCI strategy. Standard protocols were followed here, and if you see the TVF, there was not much difference. And if you see at the end of the 1 year, the event rates are so low, 3.1% and 2.5%. It's very difficult at these event rates to show a statistically significant difference in between 2 strategies. So what was their summary? OCT guided PCI was non-inferior to IVUS guided PCI with respect to primary composite endpoint of cardiac death from cardiac causes TVR at 1 year. Incidence was primary outcomes was lower than expected, possibly due to improvements in methods and techniques to perform PCI and general improvements in cardiovascular care during past few years. The amount of contrast was obviously lesser with the IVUS guided strategy. So we come to the first questions what we ask: why use? Improve surrogate endpoints. Definitely, it improves imaging, improves surrogate endpoints, and Illumin 4 showed us that. And Clinical endpoints, yes, Renovate PCI, October, network meta-analysis, all these three trials showed there is definite improvement in the clinical endpoints when you compare imaging guided PCI versus angiography guided PCI, but it was equivalent with Illumin 4. In which patients, now long lesions, we had IOS XPL data, IOS CTO data for CTOs, bifurcation, we have October, even ultimate trial and Renovate PCI also suggested bifurcations, you can, imaging guidance is better. Calcific lesion, disrupt CAD, there is a OCT sub-study which showed benefit with a OCT. Leapman, we have tremendous data, so Leapman, it's a standard indication. Yeah. All comers, network meta-analysis, Renovate PCI and ultimate trial. How to use, now this was a music criteria, this was an old criteria, this only talked about the optimization of the stent diameter, it didn't talk about the stent edges and complications. So this was the criteria, 9 millimeters is a very big area, anybody will tell you it cannot be achieved. Now this is a commonest criteria which has been used, ultimate criteria, minimal lumen CSA, more than 5 millimeters square or 90% of distal reference cross-sectional area. Plaque burden at 5 millimeter proximal and distal of stent edge less than 50% and no edge dissection of involving media with length more than 3 millimeters. This is a criteria which is commonly used nowadays, and Renovate PCI is modified little bit. It said area of more than 5.5 millimeters and it defined malappositions and edge dissections better. Malapposition was added in the Renovate PCI and they added area of MSA of 5.5. One more slide. MLD max, I think everybody is aware, I will not go into that. And this is the same case studies. Now, last question, is one better than other? I think all data showed that both imaging technologies are equally good, and there are some advantage of IOS like less contrast, better sizing, less target vessel failure in meta-analysis. Advantage of OCT is better resolution, calcium depth can be measured, faster analysis, automated measurements. And still, if you are not convinced, these are the trials which are coming up, Optimal, ISTMI, Improve, and IOS chip trials. So, class 2A indication at present, and this is a summary. Optimize PCI with imaging helps to reduce MACE, benefit all across groups and anatomies. MLD max for OCT and ultimate criteria for IOS can be used for optimization. OCT non-inferior to IOS in RCTs and meta-analysis, and key is to use any imaging which is available and patient affords. Thank you.